other kinds of adverse events that could then precipitate the onset of psychosis. So the traditional strategy for studying and treating psychotic disorders has been, or had been for many years, really looking at following the onset of this first episode. This is where we're looking to see people who are showing already signs of psychosis. We're looking at brain function, brain structure, understanding symptom presentation, and so on. But what that means in this neurodevelopmental model is that we're really focusing very late in the development of the psychotic disorder. And so understanding brain function and structure at this point is already kind of late in the process that the person may have been undergoing. And so in the more recent clinical risk strategy, there's been more of a focus on the prodromal period. This is the period that occurs prior to the syndrome of the psychotic disorder, really moving that focus of study and therefore intervention backwards in the time course of illness. And so now, looking earlier, we're able to look at potential brain changes and life experiences that may be occurring earlier on in this process in the development of psychosis. So why do we try to identify early? The first reason I alluded to is that we really, by looking early in the course of illness, we can identify, we can better understand the underlying neuropathology of schizophrenia and psychosis. And also, most importantly, one of the whole goals of the whole endeavor is really to bring more timely treatment to individuals who are beginning to develop psychotic disorder. We know that the first episode of schizophrenia often goes untreated for an average of 1 year. That can be very deleterious to the person while they're going through that process. We know that longer durations of untreated psychosis are associated with a lot more disability later on for the person. Early treatment can reduce relapse and deterioration, so the person may experience fewer relapses, fewer hospitalizations, which can be very upsetting, distressing for the individual and their family. And that early response can prevent could prevent treatment resistance, so that the interventions earlier might make it less likely that the person will suffer relapses later on. So in the model of looking strictly at psychotic symptoms, we're looking at traditional positive symptoms, which are delusions and hallucinations. These are false perceptions about reality, about things that are going on in the person's environment. There are also very impairing negative symptoms that can occur where the person has diminished facial affective expression, loss of interest, loss of motivation, thinking problems, and some disorganization as well in the way the person's speaking and the way they're behaving. And when we're looking at psychosis risk symptoms, we're really looking at all three of those categories in an attenuated form, meaning that they are not as severe, they're not as disabling, they're not as distressing to the individual as what we see in the full blown symptom. So an example for an attenuated positive thinking, the person may have some unusual thinking, have some thoughts that about things that may not be true, such as feeling as though things around them are strange or unreal, feeling as though other people in their environment are not really existing, but not really being fully convinced of that and not really being overly distressed by it at that point when they're showing this attenuated symptom. Similarly, with an attenuated form of hallucinations, the person may experience some unusual perceptual experiences, sometimes hearing the sounds that, say, they hear a fan and they feel like maybe they hear whispers coming from the fan. There really is a fan, but they are interpreting that as being voices. But they don't have the compelling sense of reality as what a true hallucination has at the point of this attenuated symptom. Similarly, we have attenuated negative symptoms, so the person may show maybe a little bit diminishment in their in the way they express emotion, but it's not really what we call flat, as what we see in the psychotic disorder. Maybe some lower motivation, withdrawal from other people. That's actually one of the first things that family and friends might notice, is that the person seems to be isolating a little bit more from other people. So when people have used those symptoms, researchers have used those symptoms to identify people who have come to clinics looking for help. So they're saying, there's something going on with me and I'm not quite sure what it is. When they've used those attenuated symptoms to try to categorize people, it has been found in a number of studies now that these symptoms do increase risk for converting to a full psychotic disorder. And what this slide is showing is accumulation of a number of different studies where you can see by 36 months, approximately 36% of individuals who had been shown those symptoms early on did convert to a full threshold psychotic disorder. So that shows that this is a risk. It's a higher risk than most other risk factors that we're aware of to have these symptoms. Now, one of the things that makes this a little bit challenging is that we know that even in the so those were people I mentioned were coming for help. Okay, so someone, either a friend, a family member, the person themselves, recognized that they were experiencing some kind of change in their function. But we know that in the general population, people who are not necessarily help-seeking, there are these psychotic-like experiences that can occur to people, and they may not necessarily be a full-blown psychotic disorder. So in the general population, in this continuum, we have a smaller percentage of people with a diagnosable psychotic disorder, about 4% showing some psychotic symptoms, and then other people who are showing some psychotic-like experiences that we wouldn't even say are, say, delusions and hallucinations. So that's a pretty large number in the population. And one of the things that makes this very challenging is that when you're looking at these kinds of symptoms in young people then, what we need to try to figure out is at what point, when a person's developing, is this group here with the psychotic-like experiences, or maybe some psychotic symptoms, likely to lead that individual to then develop an actual psychotic disorder. Because if we can, then we can maybe look at points of intervention that will allow us to halt that process in some way or ameliorate that process. So we've conducted a large-scale study of 9,500 young people. Raquel Gore is the PI of this project. In a collaboration with the Children's Hospital of Philadelphia. It was a mostly two-year project where we assessed these psychotic-like experiences in young people. And what we found as far as the psychosis spectrum symptoms is that in the general population, these were children who were not presenting for any kind of psychiatric care. They were presenting to Children's Hospital for any reason that a child might go there, for any kind of medical condition. We found that about 4% of youths reported psychotic symptoms, so pretty consistent with the population estimates. Another about 12% reported significant subpsychotic symptoms. So these were young people between the ages of 11 and 21 who were saying that they had some of these attenuated symptoms that I told you about. One of the important things here is that not only were on average, young people were experiencing these at a higher rate than you might expect, but also those symptoms were associated with functional impairment. So those, school and work, if it was an older child who was working, overall reduced global functioning. And in addition, increased odds of experiencing other kinds of problems like depression, anxiety, other kinds of behavioral disorders like ADHD, and suicidal ideation. So the existence of these symptoms in young people was not benign. So it is something that is of concern in and of itself, even at that stage. So we completed a 2-year longitudinal follow-up of 500 young people from this sample, about half of whom had shown at time 1 some of these psychosis spectrum symptoms. We wanted to see what happened because, as I mentioned, it may be that we know that these symptoms exist in the general population. If they persist? Do they go away? What happens to those symptoms when they're exhibited? And we found that in about 50% of young people, those symptoms did persist at the point of a 2-year follow-up, and including some young people who were diagnosed with psychotic disorders. We also found that in some who had not shown any symptoms at time 1, the symptoms did emerge in a small number of people who had not reported any symptoms at time 1. So what this suggests is that it's consistent with other studies that have shown that these symptoms may sort of wax and wane over time, and it's important to understand that whole developmental process that's occurring as young people are developing. The persistence of those symptoms in that group that did have persisting symptoms was predicted by baseline. So all the way back at time 1, 2 years earlier, those individuals whose symptoms persisted did have higher severity of their subclinical symptoms. So they did have higher levels of symptoms even at time 1. than the group whose symptoms did not persist. Also, they had lower functioning. So again, we see that association with overall functional impairment. And had some exposure to prior psychiatric medication, though the important thing here is that it wasn't antipsychotic medication for most of those young people. The persistent group, also very important for the topic of intervention, they did have comparatively increased treatment seeking. So if you look at this blue is the persistent group. This group we're calling resilient. Young people who at time 1 had some symptoms, but then later on didn't have the symptoms at time 2. Those with emerging symptoms and those typically developing. You see the whole cohort actually tends to talk with professionals quite regularly or frequently, even at 30% for those who are typically classifying as typically developing. But in those who had persistent symptoms, who had the highest rate of help-seeking behavior, they are talking or reaching out to counselors or psychologists, pediatricians, suggesting that there's an inroads there. There's a question as whether or not the person is actually then getting the kind of help that might be specialized for early psychosis, but young people are reaching out on average when they're experiencing these kinds of symptoms. They are talking to other people about it. So a good deal of research has gone into this concept then, if we have these windows that are happening earlier into the development of psychotic disorders, how can we intervene in a way that's phase specific to the phase that the person is in at that time? The cutting edge would be sort of prevention research. This is a slide from Barbara Kornblatt. But also this early detection. So if we're early identifying, if we're early intervening, can we alter the course of psychosis by intervening in a way that's very specific to the phase of illness the person is in at that time? When we're looking at first episode psychosis, so this is very early on in the right after the onset of a first episode, there has been now a good deal of evidence, and this is from the NIM RAISE early treatment program, that suggests that intervening very early in that early phase can improve global functioning. So this is the NAVIGATE program, which is a specialized comprehensive care for first episode psychosis. And this is increased functioning by the time of 24 months following entry into this program versus community care as usual. Similarly, these are symptom levels, and you can see in this here orange for the NAVIGATE program that the symptom levels are lower compared to community care. So the specialized intervention, that phase-specific intervention, does seem to help in some ways. So early psychosis presents us this unique opportunity for intervention. Decreasing the duration of untreated psychosis is a high priority, as I mentioned, so really getting people to that clinical care, which we hope can prevent chronic illness and disability. And then ideally, these specialized phase-specific intervention services can improve symptoms and clinical course, increase retention in treatment programs, improve outcome, and reduce the overall cost of treatment for the individual and for society. And so as a result, in large part from this, the NAVIGATE, RAISE NAVIGATE, starting in 2013, Congress did allocate funds to be distributed through SAMHSA at the state level, dedicated to the treatment for those with early serious mental illness. So that's a very positive development for the field. Really looking at evidence-based treatments for first episode psychosis, the components of coordinated specialty care model. And that was implemented in 28 states in 2015, and Pennsylvania now has, as of this year, 8 programs, and the funding has been increased for 2017. So some very positive developments following from this early intervention efforts. So we have a program also that I'll tell you a little bit about, which is the Penn Psychosis Evaluation and Recovery Center, which attempts to implement some of the different components that have been shown to be effective in early psychosis. It's directed by Christian Kohler in our center. We include young people who have early warning signs of psychosis, so some of those early symptoms that I told you about, or onset of psychosis within the past 3 years. We're really focusing on young people who are entering into and passing through the age of risk, 14 to 35. And We include multiple components, including community outreach, so talking to people about the work that we're doing, trying to raise awareness about these early signs and symptoms of psychosis, assessment, really comprehensive assessment of all of the domains of symptoms and functioning that can be impaired in people with psychosis, really coming up with a recovery plan using a recovery model where we're looking to say, this is an episode, let's get back on track with all of the different things that can go off track when someone experiences an episode of psychosis. Using cognitive behavioral therapy, which is from the Aaron Beck's group, specialized training in that's recovery-oriented cognitive therapy, and psychopharmacology, so medication management where needed. Cognitive remediation, which is a program that's used to try to address some of those cognitive difficulties that people may experience, problems with attention and memory that often are associated with a first episode or early symptoms of psychosis. And then multifamily group psychoeducation. Many families come to us and really kind of flabbergasted by what's happened to their family member, and not really understanding or having any kind of framework to try to understand what's happening here and what's likely to happen next. What is the medicines, the symptoms, all of those different things, the functioning, all of those things. And so we have a regular psychoeducation group, and then also efforts to really help with the occupational functioning the person has, going back to work, going back to school, trying to get back the level of functioning, as well as we know that's a very important area to sort of really focus on. So we had, at this point, this was actually July, 87 patients, and now we have actually over 100 subjects now, participants now. We mostly have people who we classify as having schizophrenia, but you can see there's a number of other psychotic disorders represented, and also clinical high risk. We tend not to really focus on the diagnosis itself at this stage. We're really focusing on the symptoms and experiences that the person has that we can then target in this recovery planning. So we have good utilization across all of those different components that we told you about, and some very basic symptom measures showing improvements in mood, in anxiety, and in sleep by a 6-month follow-up. Also in functional improvement, so with daily activities, people are doing a little bit better with getting back to work. School is, here in this sample, it's about 6-month follow-up. We're still working on that. But really an increase in structured activity and a decrease in unstructured activity. Independent living skills being higher at follow-up, levels of functioning higher at follow-up, as reported by both clinicians and a family member. So where to go from here? I mean, there's a lot that can be done. I put down a few different things. I think one of the things that really highlights when I talked about the community sample that we studied, where we're looking and we see there's young people experiencing symptoms, there's young people reaching out to some kind of mental health care provider, if it's a school counselor, if it's a pediatrician. We really want to try to narrow that gap between early identification and getting that person to the appropriate kind of intervention, right? So there's an opportunity here to potentially screen, so with greater awareness from mental health care providers, but also from pediatricians and other people who may be in contact with young people, to be able to screen for some of these unusual thoughts or behaviors that may be occurring that you might never know about unless you specifically ask for them. And also, then once those are identified, there has to be a pathway that allows the person to get to a specialized care place. Otherwise, it's like, you have the identification, but where does the person go? And I think that is one of the biggest things when families come to us, they say, it took us a while to find you. We took a while for us to get here. Like, how do we get from identifying and knowing that there's something going on to a specialty care model? And part of the problem is there simply aren't enough at this point in time covering enough of a geographical region to be able to accommodate the volume of people we know out there are experiencing these kinds of symptoms. So we do want to strengthen that referral pathway to specialty care, but we also know that we need to really increase the capacity for those care programs to be able to accommodate the young people. But also then focusing on really increasing the efficacy of our first episode program. So in our PERC program, we have a number of different goals. Family engagement and support is very important for the success, and we continually work on improving that. Peer support, which is one of the things that Mark mentioned, we are interested in developing that further. occupational and vocational services, really strengthening that. The program, Peace Program, is another complementary program to our program that's run by Dr. Irene Herford. And we are trying to increase our collaboration there to increase the impact that we may have, and also to help in the evaluation of all of the 8 Pennsylvania programs that are existing right now. We're running the program evaluation for that. Also I think collaborating to enhance the systems of available services. So that's a big part of what I just said, is that we need more services for people in this phase of illness on both a local and statewide level. So for example, with the vocational, we've established a collaboration with Community Integrated Services, who is a vendor for OVR. We've had a lot of people come to us and say trying to work through OVR and trying to get back to work is very, very difficult, especially for the young people who are experiencing these symptoms. And so really trying to shore up that pipeline at a broader statewide level would be really, really helpful. And also collaborating with mental health associates to increase peer support. So collaboration, I think, with systems. So if we're thinking about systems of a pathway to care, and really then shoring up the whole pipeline of that care, I think that is what we would like to do. So thank you very much for your time.